Hey guys, so welcome back. We're going to talk about reliability, and some of you might be also watching a video on validity today. I'm going to try and give a similar introduction to both of those, just depending on what order you've watched them. But basically, we're coming out of this discussion of statistics and understanding them. And remember, the focus is on making good clinical decisions. We're not here to understand the math underlying all the statistics, and we're not going to be experts on test development or research processes. We want to know enough to be able to be good consumers and use those for clinical or otherwise counseling purposes. So remember, that's the focus. Now, let's just remind ourselves quickly of what validity and reliability are. Validity is the test measuring what it's intending to measure. In the other video, we'll talk about that in more detail. Reliability is, think about the term reliable. If you show up for your friends when they need you, and then the next time they need you, you're like nowhere to be found, you're considered to be an unreliable person, right? So if you're always there for your friends, whenever they need you, they're gonna be like, oh, you are just the most reliable person. It's kind of like that when we're talking about testing and assessment processes. If the test is reliable, it's going to give you the same results in different circumstances. And those circumstances are what we're going to talk about today. But it might be you take the test one day, you do it again the next day, same result, or next year, same result. It might be that you have two versions of the test and you're going to use them at the same time with the person to figure out if the test is reliable, you'll get the same result on both versions of the test. Or maybe one person goes in and gets tested at your counseling center and then they go across town and they get the same result. Then within the community, different raters, it's called inter-rater reliability. We'll talk about that in a second. There's reliability in the process amongst professionals. So these are the kind of concepts. So it's not just reliability over time, but it's over space and within people and all that kind of stuff. So there's more nuance to it that we'll jump into here. Now, so I guess I'll repeat myself a little bit here. We can also use words like consistency, dependability, reproducibility. These are all kind of in the same wheelhouse. They're not technically exactly the same as statistical reliability or procedural reliability, but they're kind of, it'll get you at the gist of what we're really getting at here. So in other words, your job is to help people understand how good an assessment is and how it isn't, or how good the process is and how it isn't. And so when people are like, how can I trust you? How do I know that what you're doing is going to be beneficial or it's going to give me good information? Well, this is one of the ways that we can talk about that and help people understand and trust the process, that kind of stuff. So that's kind of what we're going for here. It also means that if we're using this information to make choices, clinical choices for our clients, or even in non-clinical counseling settings, we just want to know the information is good and how we talk about that and how we understand it. The scientific process has broken this testing stuff down in so much detail, and we want to be good consumers of that. One of the analogies that I like to use sometimes is that if you go to Spain, you don't necessarily have to be a fluent speaker. You don't have to be able to talk about all things Spanish, but what you do need to be able to do is understand enough from other people to be a good consumer and make good choices in your travels, something like that. So that's what we're going for here. One of the things you'll hear from people a lot is, oh, if I would have taken this test at a different day, or I wouldn't have had that bad driving experience before I got to the center, or if I didn't have a headache or something, I could do better. Especially if it's like a performance test, like the GRE or something. I could do better next time. Let me take it again and see. And that's what we're trying to understand here is, could you do better next time? And what are the things that are getting in the way of you doing better? And so that'll help us understand this reliability issue. So let's talk about this. Something we haven't talked about, I've alluded to this a little bit before. But we have something called an observed score, and then there's this thing called the true score. Now think about it this way. If you had like a God's eye view of knowing everything in the world, and you could see all of the nuances and circumstances and all of the variables that have relationship with different things, and you could see everything, you would be able to have access to the true score. In other words, well, hopefully that makes sense to you. The observed score is what we see. So let's say a person comes in, here's the example that I like to give all the time, is that someone comes into your counseling center and they are just bubbly and they're like, I'm here to get treatment. And you're like, great, good, thanks for coming. Hopefully you don't act that sarcastic and passive aggressive. Well, let me do this again. Great, thank you for coming. It's good to see you today. Tell me about your life. And they start telling you, oh, I'm so depressed. I'm just unhappy and unmotivated, whatever. And you're like, huh, really? Because I observe you being kind of bubbly and you seem pretty outgoing. And so I'm just trying to understand what you're telling me versus what I'm seeing. There seems to be a discrepancy there. And you come to learn that they actually are depressed, but it just so happens that an ice cream truck pulled up right in front of your counseling business, and this person just loaded up on like mint chocolate chip or whatever their favorite ice cream is. Whatever your favorite ice cream is, just imagine that. So there is what's actually happening, the true score, and then there's what we see, the observed score. And the difference is the measurement error. What we're trying to understand here is what's getting in the way. So as we talk about validity and reliability, there's always going to be this noise, this interference, this stuff that's just getting in the way. And that's what we call measurement error. Now, there's different kinds of things that get in the way, but what we're going to talk about here is the mathematical process of how we know how much is getting in the way. There is a way to do that. The details of it are extremely complicated. Well, they're not extremely. They can be complicated, and there's different kinds. So I'm going to talk about some of them, not all of them, but I'll just give you a sense of them here. One of the sources of measurement error is time sampling error. In other words, the performance on a test can change over time. So let's say I go in, I take a test, and then I come back a day later, and just because time passed, I get smarter, I get older. Maybe I watched like 30 episodes of Jeopardy. Well, that's a bad example. Let's say I just in the process of me getting older. Here's a better example. Let's say I'm 11 years old and I take a test and then I drop out of school. And so I'm not learning more information, but then I come back when I'm 12 and I have the same exact education, I have the same exact amount of training, but just because my brain has grown and developed, time passing means that I'm going to get different results. And so tests given over time are always going to include some amount of time sampling error. All other things being equal, just the time passing. That's what we're talking about here. Another source of measurement error is content sampling error. Test items do not adequately represent a construct. So if you haven't watched the validity video yet, what we're talking about here is that the content of the test just doesn't fit what it's intending to be measured. And you're thinking maybe, well, that sounds like a validity problem and not a reliability problem. And it is. There's something that these concepts are sort of related. And I don't want to confuse you too much by explaining all the details of how they're related, which also lets me off the hook because then I don't have to fumble around and sound like an idiot if I don't get it right. But the idea is that, remember, we're talking about reliability here. We're not talking about validity problems. We're talking about content over time can change. And so it's not the person just by virtue of time that gets different results, but the content itself changes over time too. And so the content can be unreliable, not just the test taker, something like that. It's more detailed and nuanced than that, but we'll just leave it at that for now. Just know that different things can change over time. I'll explain that. Here's an example that might help clarify this. If you're testing for autism, and this is before the DSM-5, we used to have a different understanding of what the clinical criteria were for autism, and we even included these conditions like Asperger's degrees and pervasive developmental disorder and just different kinds of things that sort of look like autism. However, when the DSM-5 came out, we have a different category. We give it a different name. People are still living the same lives, and the people haven't changed, but the way we understand them do. And so a test developed for the DSM-4 is going to have, it's going to produce unreliable results after the DSM-5 comes out because the content is sampling differently. Hopefully that makes a little bit of sense. I thought that analogy might help a little bit, but either way. I alluded to inter-rater differences, and this one's a big issue. I think it's a big issue in clinical practices around the world. Ideally, if we're all trained perfectly well and we all get out and we have very similar experiences in the world, we can all identify the conditions that exist. It's the reason why we standardize a process, because if we standardize the process and the knowledge and we have something like the DSM, it's not perfect. It's not the most ideal thing in the world to use this because there's so much more to know about a person's barriers to growth and barriers to functioning and all that kind of stuff. But having some standard means that we can then talk about the same concepts together. And if we have standardized assessments, we can follow the same process. If we don't, the risk that we run is that you across town and me might look at a person and say, you might think they're depressed, I might not, and we say, oh, you say they're depressed, I say, no, you're really not, and we're going to come to different conclusions, but the person's going to remain the same. Or even if we're using a standardized test and I subtly give positive reinforcement through the test and the person has a more, uplifting experience being with Dr. Aaron as opposed to Dr. So-and-so across town or whatever, that means that we're going to get different results, but the person's going to stay the same. So there's a lot to unpack there in terms of how this happens in clinical practice. But just know for our purposes today that tends to be a problem, and people, it's not necessarily that it's like, oh, it's so bad, it's going to ruin people, and it just invalidates the process, and that this counseling stuff is just a whole bunch of hocus pocus, whatever. It's not. However, the more that happens, the more difficult it gets for people to trust us. It's just like when you go to the doctor and one person says something and you're like, I want a second opinion. That person says something else. You either don't trust the doctor or you don't trust the process. Ideally, in a perfect world, clients would trust the process, but they would just maybe not trust one of us. So just a quick aside about that. One of the things that I think can be helpful to talk to clients about is that I'm going to give you this test. And what that means is that if we're using this test, you don't have to trust me. You can trust all the people that validated the test, the people who put all their time, blood, sweat, and tears into developing it, the scientific process. You don't have to put all of your faith in me. You put it in the counseling process. And I would rather people do that than just trust a guy or a gal, something like that. That can be really helpful in clients investing in their own results as opposed to investing in you as the therapist or the counselor. And I think that can be not only is it good for the profession, it's good for you ultimately, because then you can talk about how you might have made a mistake, but, and kind of walk it back if you need to, or say, I did the best with what I have, but now here's a new information or something. It just gives you a lot more flexibility to function professionally, as opposed to just saying like, I'm a pro, I heal people. It's not how this is supposed to work. So anyway, enough said about that for now. There are other sources of measurement error too. There's tons of them. The quality of the test items, the test length. In other words, if I have a 5,000 question test and somebody accurately answers a question right in the beginning of the test, but then doesn't by the end, the test length alone is going to cause fatigue, and that means they're going to get different results and they're not reliable questions because of just length and stress on the person as they're taking it. So that's what makes it a reliability issue. Test administration, I kind of just mentioned that if there's a standardized test and I give it in a non-standardized way, I'm creating reliability consistency issues between raters and between test takers and all that stuff. So it's just, that's why we have a standardized process. Okay. Now I'm going to confuse you more. I apologize, but it's just going to happen. Remember last week when we were talking about correlations, and we talked about how the statistical world and the assessment development world, they use this code because every profession or specialty practice or whatever has a jargon that's associated with it. And the Greek letters and the mathematical symbols, those are all really unique and specific to statistical work, right? the correlation is represented by a small italicized R. So what do you think when we're talking about reliability? What do you think represents reliability? You guessed it, a small italicized R. Now, how do we know what is the difference? Well, that comes with context clues. Remember back from your English classes when you were in, I don't know, 5th, 6th grade, college, whatever grade it was, and people say, you might use the same word, but it means different things based on context. Well, that's kind of what we're talking about here. It's frustrating when you're learning because it's hard to tell the difference, but once you get it, it's okay and it makes sense. So if you're like, why do they have to do it? Why do they have to make it so hard? Well, it's because that's just how it happens. Sorry. But, so just so you know, if you see a small italicized R, depending on the context, it might mean correlation or reliability. Okay. Now, there are different ways of testing reliability, and I've mentioned this before. One of the ways is test retest. That's the one that most people are familiar with. Someone comes in, session 1, you say, okay, let's take a few tests. You give them to them and you get what we call a baseline. And then after you have the baseline functioning, whatever, you do 1 or 2 or 3 sessions of treatment, and then you test them again and you say, oh, we've improved. Isn't life wonderful? We're doing such a good job because we retested and you got better. Doctors use this all the time when you go in for doctor visits. They say, oh, you were sick last time with a cold. Now you're not sick. We tested, we retested, and we know the process is reliable, therefore you are healed. And you can verify that with your own experience and say, like, yeah, I don't have a sore throat anymore, so it's good, right? So test, retest. There's also alternate forms. So if somebody, what's the one? I'm blanking right now on the, I'm having lots of brain fart moments this summer. I don't usually have these many, but something's going on in my life. I got to figure that out, but that's just a useless aside. Anyway, there are alternate forms, and there's a test that I can't think about what the name of it is now, but we'll cover it later in the class. There's a blue form and a green form, and sometimes they're given back to back. And the reason for that is if I give one test, one variation of the test or one version, I give you the blue one, but I'm not going to be able to see you back in a week to make sure I give you a second test to make sure the test is reliable and the results I have are good. So I'm just going to give you both the blue and the green form. And if I get the same results on the blue form as the green form, then I can say these results are trustworthy because they're reliable among different versions of the test. Okay, so that's one way that a person could potentially validate a test. One thing you all in the class here have done is you used 2 different versions of like a depression inventory or an anxiety inventory. If I give you the Beck's depression inventory and then I give you the PHQ-9, they're essentially supposed to get at the same exact symptoms based on the same clinical criteria, but they're 2 different tests. And if I get different results on them, I have a concern about reliability, right? So that way I can say, oh, something seems fishy here. Something's wrong either in the test or with the person or with the process that I've delivered it or something like that. So that's another alternative. There's also internal consistency. So if I ask a question at the beginning of a test and a very similar, if not same question at the end of the test and I get different results, that's within the test. It's internal to the way the test is given. That's an internal consistency, or you could, I guess, say inconsistency in results, depending. And then there's the inter-rater reliability. I've already explained that one, so we'll kind of skip that one and move on for now. Testing reliability is essentially comparing between 2 scores from 2 times taking the test, 2 forms or 2 halves, same test or 2 raters. Essentially what we're doing is just measuring scores to each other, and that's how we tell, okay? So I don't think there's anything more else to say about that, but that's what we're trying to do here. The one thing you need to know about this too, and this is going to be true of validity, and it's true of some other concepts that we've talked about when it comes to just statistics, is that you don't need to memorize this stuff. You don't need to always memorize, like, okay, when I'm validating a test or when I'm looking at the reliability because I'm choosing a new test for my agency, you're probably not choosing new tests every week or even maybe every year. You find one once and then it might be a little while before you change your assessment process, or you see a different kind of client that is requiring a different kind of test, something like that. So you don't have to memorize all of these concepts, but what you do have to do is you have to know how to use your resources. So on table 7.1 in the 9th edition, which is page 138, there's a comprehensive list, and it's good for those of you who want to have some sort of reference later on. Okay, now we're going to get into a little bit of the detail, a little bit more. I've given you some examples and we've talked about these things, but let's talk about the test retest in terms of how that shows up in the clinical counseling process. So one of the things that you want to think about when you're deciding, how do I want to do this with clients? Think about the time it takes to take a test, time in between administrations. So here's an example, just to use a sort of basic, easy one. If you're talking about depression cycles, how often do you think depression changes in people? Is it every minute? Is it every hour, every week? Depression symptoms can change, but typically they, in subtle ways, they can change from day to day. But it depends on the person, and sometimes they might go through, like if someone's experiencing, bipolar conditions, they might go through bouts of depression that last for days or even weeks. If somebody has major depressive disorder, it might be like this chronic, unchanging malaise that lives over the top of somebody's life that really doesn't change that much, and it just lasts for a really long time. So when you're thinking about your testing cycles, if a person is showing symptoms of bipolar and you're like, okay, I tested them and they have severe depression. They came back 3 weeks later and I tested them again and they don't. And I can't figure out. I'm pulling my hair out trying to understand what's going on. And then another client just shows consistently high levels of depression. You get to say, how am I using this test? How am I, is the time for retest appropriate or not? Because as you come to learn about the person who lives with bipolar, you're going to want to test while they're active in their cycles. And it might be days, weeks, months, or years even between cycles of bipolar. And so the timing is kind of important there, right? Because if you're measuring what do the lows look like compared to the highs of mania and the lows of depression, if you test, if their cycle runs on every month, we'll just say, and you test every 2 weeks, you're going to have a really low and then a really not so low because they're not depressed during their manic cycles. And then you'll get another one and you're going to be like, what the heck is going on? So being very intentional about when you choose to offer a test really will matter in terms of what clinical impression shows up, okay? I think that's probably pretty intuitive for most of us, but it can be confusing at first when you're learning this stuff because you're like, why did I gave the test, I did what my supervisor said, you just give it to everybody all the time, or you just you can choose when to use it, but I don't know when to use it. Well, you get to choose. That's the whole point, is that you order the test. Like a doctor is going to say, I'm not just going to give everybody a test for the COVID-19 vaccine. It kind of was a thing that was situationally important, and now maybe it's less important. Or I don't know, I don't want to be controversial about it, but hopefully you get the idea there. Number 2 is you need to understand the construct being tested. In other words, something like if you give a personality test, like the Myers-Briggs, we've all taken these and we talk about them in classes. We're like, oh, I like the personality test, and I've gotten the same results every single time, and it really shows me that I'm the same person. But most of us don't have that experience. Most of us are like, well, it changed slightly, and so that means the test isn't good, right? But why is that? If I give a depression inventory once and then give it after 6 sessions of counseling, we might see progress, but we wouldn't expect that to be weird. But if we give a personality inventory after 6 sessions of counseling, we would say, but personality is a construct that is stable and reliable and stays consistent over time, whereas depression can come and go. So when we talk about understanding the construct, one of the things we want to know is depression likely to be something that comes and goes with this client? Is personality something that changes rapidly over time, or not so much? Because personality is supposed to be one of those things that is stable over many, many, many years. It can change, but it's not really likely to change unless there's some, significant outside forces at play here. One One exception to that, that's the word I was looking for. One exception to that is if somebody has like dissociative identity disorder and their personality changes rapidly from one to another, two different personalities, that would be a good indicator that there maybe is a disorder going on, because personality doesn't typically do that, right? So if we understand the construct of personality as being stable over time, and then we see a rapid fluctuation, that's an indicator that there might be a clinical condition present here that we need to pay attention to, something like that. Okay, alternate forms, we've already talked about this. I think probably I mentioned most of this stuff before, but there's different ways of doing this. There's, if I have two forms, there's simultaneous administration. I can give two forms in the same day, or delayed administration, two forms on different days. Both of those, I don't need to go into too much detail here, but those can be two alternatives that can help you in different kinds of situations. So I'm not going to explain that one in much more detail here, but just know that you have the potential, if you have a good, thoughtful, intentional reason for using tests a certain way, that's the kind of flexibility that you have. Now, some test developers will say, here's how the test is intended to be used, and if you do it another way, it's going to invalidate the results, or it won't give you reliable results, so follow those instructions very closely. Other test takers will give you options like this and say, you really have the flexibility to choose here, so if you have thoughtful, intentional reasons for doing so, go for it. And so just know that you can do those things, I guess. I've already explained internal consistency here a little bit, but there is a point that I want to make about something that I had said a couple weeks ago that you've probably already forgotten, but here it is again. There are all kinds of ways of, statistically anyway, doing what we call post hoc analyses. And what that means is that after we do one calculation, we can find out, sort of protect the data from measurement error. Remember when I used that term? This one here. If I want to get closer to the true score and I want to minimize that measurement error, I can do certain kinds of post hoc analyses to make sure I get there. Now, what that means, I'm not going to go into detail here, but just know that there are ways to protect the internal consistency of test measurement if I want to. Now, well, that's enough said about that. What else do I want to say? The one thing I will mention here is this term right here above my finger, right there, Cronbach's alpha. If you're reading research, you'll very often hear something about like the Cronbach's alpha score, or just somebody will say alpha score. Cronbach is the guy who developed that calculation process. Alpha scores, that whenever somebody says that, they're talking about reliability. So let's say somebody's doing a test on, they're doing a research project on I don't know, some new nursing care facility process or treatment method or something like that. And they're using a depression inventory to measure if their treatment process is effective and working. And they want to show that the measurement tools that they're using are useful and they're sound and they're good quality. They'll report the alpha scores of 0.86 or something like that. And if they just say like the alpha scores of this tool are 0.86, what we can then do is say, is 0.86 a good number? We'll talk about it in a second. And then we'll go, yep, it's a good number. Therefore, we can rely on that tool to be used as a good use of determining whether their process is effective or something like that. So that's one that you'll want to pay attention to, or at least remember that that's an important term or concept. Okay. What else do I want to say about this one? Here again, there's that inter-rater reliability stuff that is so important. I think I'll save that for like an in-class discussion or something. We can talk more about that. Now, one of the things that will be probably kind of frustrating and difficult here is when we talk about correlation coefficients in past weeks, one of the things we said was, well, how do we know if a correlation is strong? And we know that If it's between -1 and +1, it tells us something about the direction. And the closer it is to -1 or +1, that means the more strong the relationship is. But is 0.7 indicating acceptable strength, or does it say something meaningful about it, or is only above 0.8 that it's meaningful? We have a scale to help us understand those things. Same thing about validity. You'll get that in another video. But reliability coefficients are reported in as a measurement between 0 and 1. In other words, this example down here, the reliability coefficient, remember that small italicized R, of 0.95, what that essentially means is that 90% of the variation in test scores is explained by real differences. Well, what the heck does that mean? Remember, if I'm trying to understand a person's score, if it's 100% reliable and I score a 5 on one test and then a week later I score another 5, then I can say this test is perfectly reliable and I get the same consistent results, and if everything were equal in my life and nothing changed, then we could say perfect reliability. However, if I get a 5 one week and a 4 in the next week, we can assume that there's some error in the process, right? Like that just exists there as measurement error. And what that means is that 95% of the test explains the real condition that's going on, but there's a certain amount of error in the process, and that's what the 0.95 means. It tells us how much error we're experiencing, okay? So the question then becomes, how much error is acceptable? So when you're looking at reliability measures, this is one of those charts that you don't have to memorize this, but you'll want to be able to reference. If somebody says alpha scores of, or reliability coefficients of, or something like that, you'll want to be able to come back to something like this, either on this slide, or you Google it, or search for it on some other search engine on the internet, whatever. And this is going to be standard for all reliability scores. So if you see anything above 0.7, you'll say, yep, this tool is acceptably reliable. If you find something that's 0.69 or below, there's probably a reason for concern or question. Now remember something too that we've said in the past is that a test may be reliable with a certain population, but maybe not with others. And so if you see information about the test shows reliability of 0.9 with white college males, but when it comes to middle-aged Native American women, the reliability is a little bit different because there's more error in the process, then you may see something like that if you're looking at research or something like that. So let's see, what else do I want to say about that? If you really want to look at how this works in practice, here's a link and you can try to read through how the reliability coefficients show up in real research. I don't remember what that article was that I put in there, but I'm pretty sure it's from a friend of mine who, well, an acquaintance, we'll say. But she is an absolute whiz with statistics and reporting statistical results and that kind of stuff. And you can see a really complicated article that talks about reliability coefficients, and you can get an example of how they show up in research. You can use that one. There's also another thing that I can't show right now because I'm having trouble with my second camera. But if you want to see what measurement error reporting looks like in a test like the 16 PF or 16 personality factors, on page 321, there's an example of that. I'll go over that in class probably, and so you can watch the class recording if you really want to get more detail about this. Okay, now we're going to switch gears just a little bit. I'm pretty sure this is the last slide. Yep. This is the last slide, and we're going to talk about confidence intervals. Now, confidence intervals are something that I've alluded to in past weeks, but I said, we'll get there, we'll talk about them, we'll get there eventually. And they're in the chapter on reliability because one of the things we want to know is how much error is in a process, right? Observed scores, true scores, all that kind of stuff. And we can tell how much error is in there. But one thing confidence intervals do for us, they can tell us with a certain amount of confidence, how much can we trust this score? In other words, if I were to take the score again, I would know how much error is in the process, but I wouldn't know how much I'm likely to change, how much my score is going to change from one administration to another, or from one test version to another or something. That's where confidence intervals come in. So essentially what a confidence interval means, and I'll say this in the technical way and then I'll explain it. You'll see in a person's score of, let's say a person scores 55. And if that person has a confidence interval of 3 at 99.5%, and those confidence intervals will change from 99, 95, sometimes even 90, depending, that means that if I were to take that test again, remember I scored 55 now, confidence interval of 3. If I were to take it again, I can be 99.5% confident that I'm not going to score 3 points higher or 3 points lower. Sorry, I said that wrong. That I could score 3 points higher, 3 points lower, but beyond that, it's probably not going to happen, okay? So let me explain that again, I'll say it in other words. If I come back for a second administration and there's a confidence interval of 3, that means that I'm probably not going to score lower, and by probably, I mean I'm 99.5% confident that I won't score lower than 52, because 55 minus 3 is 52. And I won't score higher than 58 because 55 plus 3 is 58. So that's my window of, if I take the test again, I'm not going to score lower than 52 or higher than 58. And I'm 95% confident about that based on how much error I know is in the process. Okay. So we'll see some examples and I'll show you those in class. Unfortunately, I can't show you those right now because my camera is having some troubles. But one of the things, this will show up sometimes in number form, like in a table, you'll see confidence intervals and they'll show the low end and the high end of whatever score is potential. Sometimes they'll just say like confidence interval of 5.23 and you have to do the math yourself. Other times, and this is what you'll see on page 321. Other times you'll see a score and in the book it shows up as like a little diamond thing. And then you'll see these little bars on the outside of them. It'll show how much fluctuation is due to error. Sometimes you'll see things like a graphical picture of like, you'll see a little dot in the middle and then like 2 bars coming off of the sides. And it's possible that your score could have fluctuated that much just due to error. Most of the time you'll see numbers though, and they'll say confidence interval, and it'll show exactly what the low end and the high end of what was potential for that person. Remember earlier when I was having that brain fart and I said there's a blue version and a green version? This is the test that I was talking about. It's the Wide Range Achievement Test, or the RAT. It's now in its 5th version. You can see examples of confidence intervals on page 244. For the key math, we talked about that one in class in past weeks, or you can look at the examples of the RAT on page 239, and you'll see examples of confidence intervals in there. Again, I'll cover those in class. Because my camera's not working, I can't do it now, but I'll show you those and what they look like and how they work in different place. So that's it. That's all over. If you're watching the other validity video, if you already saw it, then you're done. If you want to go after this, then you have a little bit more to go here, but trying to keep these as short as I can so you have plenty of time to squeeze them into a week if you need to. So thanks for hanging out with me, and I will talk to you again on the next one. Bye.